Thank you, Harley. Can everyone hear me all right? Wonderful. It's good to be here with you today. These are very, very challenging times for many of us in many ways, and I'm happy to be sharing space with you today. I'd like to begin with a land acknowledgement. We acknowledge that Cuyahoga County is located on the ancestral, traditional, and contemporary lands of the Lenape, Shawnee, Wyandot, Miami, Ottawa, Potawatomi, and other Great Lakes tribes. We acknowledge the thousands of Native Americans who now call Northeast Ohio home. Case Western Reserve University and the greater Cleveland area occupy land taken from 1,100 chiefs and warriors who were coerced into signing the Treaty of Greenville in 1795. We recognize, support, and advocate for historic Indigenous communities in Ohio, for Indigenous individuals and communities who live here now, and those who are forcibly removed from their homelands. We will work to hold Case Western Reserve University more accountable to the needs of Native American and Indigenous peoples. So I just wanted to share a tiny bit about myself and why I'm standing here in front of you today talking about the work that I do. Well, you've already heard from Harley a little bit about my academic training, but I came out when I was 15 in Seattle, and I've been doing youth advocacy work around LGBTQ youth for over 25 years. I also have worked as an educator in public schools and middle schools, and have a strong ethos around education for empowerment. These are some of the social identities that I hold and groups that I belong to that shape who I am in the world, how I show up in space, and motivate me to do the work that I do. And finally, and most important, I am a mama, a partner. I am now a cross-stitcher. Thank you, pandemic and long COVID, a gardener and an animal lover. So I want to do three things today. First, I'd like to talk about the landscape of suicidality among sexual and gender minority youth, why SGM affirming care matters, and finally, I'm going to talk about how minority stress, queer community response, and systems thinking can intervene in the significant public health crisis. There are many groups, individuals, that have been a part of the work that I've been engaged with as funders, as participants, as co-collaborators, and so I wanted to take a moment to acknowledge that here. But first, I think we need to acknowledge the current political landscape that we're in. This is a rapidly shifting terrain for folks that are doing advocacy and activism work on the ground in and with our communities. You're very familiar with what's happening. Last time I checked, Human Rights Campaign is tracking 340 anti-LGBTQ bills introduced in state houses across the country, and 150 of these specifically restrict the rights of transgender people. And this is the highest number of new bills introduced in the year. We're only 3 months into 2023, and this is what's happening. Of real crucial importance, 90 bills are currently in action that would prevent trans youth from being able to access age-appropriate, medically necessary, and best practice healthcare, and 2 have already become law in Utah and South Dakota. Here in Ohio, folks have probably been talking about House Bill 454, which is now House Bill 68, has come back into the State House. This is a so-called Saving Adolescents from Experimentation Act that would ban gender-affirming care for trans minors in Ohio. There are 2 bills currently, House Bill 322 and 327, both address critical race theory and teaching of power, privilege, oppression within K-12 public schools. And there's finally House Bill 6, which is aimed at trans girls and prohibiting them from participating in sports. When we look at the landscape of suicidality among sexual and gender minority youth, this is what the research shows us. LGBTQ plus youth have 2 to 4 times increased risk of suicide attempt compared to non, 4 times greater ideation compared to heterosexual youth, 8 times greater suicidal ideation for trans youth compared to cis youth, and there are well-established risk factors that we know about that contribute to this disproportionate suicidality among LGBTQ youth. And those include caregiver and family rejection, SGM-based abuse and neglect, peer bullying and victimization, and internalized queerphobia. When we turn to systems-involved youth, and this is where my work is really situated, child welfare and juvenile court-involved youth have approximately 3 times the greater risk for suicide ideation, attempts, and completions compared to non-system-involved youth. And we also know that sexual and gender minority youth are disproportionately overrepresented in these systems, with estimates ranging between 16 and 32%, compared to 2.8%. There are some problems around conducting research among SGM youth inside of child welfare and juvenile court systems because we don't make these systems collect data about sexual and gender minority status. And so there's not consistency in how data is collected. There's also not consistency in how the questions are asked to collect these data in culturally appropriate and affirmative ways. So what you're seeing here in terms of prevalence rates, these are from studies that looked at counties, or a couple different counties, LA County, Cuyahoga County, and one study that used NSCA data, which is child welfare data, that is nationally representative. However, it has limitations as well. But this is typically what we see, 16 to 32% across these systems. All right, we also know for a fact, undisputed, that sexual and gender minority affirming care is essential. It saves lives. It validates a wide range of identities as normal and healthy, and addresses the societal impacts of discrimination, pathology, etc., on youth's lives. So this I'm stating as a clear, research-based fact. Affirmative care saves lives. One of the studies that I contributed to was a pilot study looking at the intersection of foster care involvement and LGBTQ status on psychological comorbidities. And this is a study that came out of a larger project involving DCFS here in Cuyahoga County, who received a grant from the Administration of Children and Families for a Quality Improvement Center to improve services and outcomes for sexual and gender minority youth involved in child welfare. This gave us an opportunity to work with community-based partners and develop our own pilot study to collect additional data on the experiences of sexual and gender minority youth involved in the child welfare system here. Over the course of our study, we were able to collect a total of 35 participants. I could talk a lot about what it's like to recruit individuals who are sexual and gender minorities and also in foster care into studies. People were moving around a lot. There was people being moved out of state, people going into residential treatments, a lot of different flux and things happening. The mean age of our study sample is 19 years, and the racial and ethnic breakdown here reflects that of DCFS in Cuyahoga County. So you can see the racial disproportionality as well. In our sample, we also had over half of the young people identifying as trans or gender diverse, and the breakdown was pretty much equal between those identifying as trans feminine, as trans masculine, and then 11% as gender diverse. We also looked at sexual orientation, so we had 43% identified as lesbian or gay, 37% as bisexual or pansexual, and 20% as heterosexual, and all those that identified as heterosexual also identified as transgender. I'm now going to share some of the results from this pilot study. I just wanted to give a pause and give a warning, essentially, that some of the information includes qualitative quotes from young people that include instances of violence and ideation and attempt. So if you need to take care of yourself in any way, just putting that out there. I am going to be reading the quotes out loud, so you know. So the first thing that we looked at was just prevalence rates. 69% of our youth had experienced homelessness. But the bigger question we then asked is, if you ran away from a placement, did you run away because it was abusive or unaccepting of your sexual orientation and or your gender identity and expression? And 47% of those that had run away said, yes, I ran away because of homophobia, transphobia, queerphobia, violence, abuse inside that placement, that foster care placement. I had a foster mom that said I walked like a girl, and she told me that she don't want a faggot in her house or whatever the hell I am. She said it one time, and that's when I ran away at age 13. The next thing we looked at, because it's a small sample size, we wanted to know what proportion of the sample met the clinical threshold for mood disorders, so depression and anxiety. And when we looked at the borderline and clinical threshold, lesbian and gay young people in this study, 78.5% were at clinical threshold. And 91.6% of the pan and bisexual individuals met the clinical threshold for a mood disorder. When we looked by gender identity, 75% of cis women met the clinical threshold for depression and anxiety, 100% of cis men, 80% of the transgender individuals in the study, and 100% of the gender diverse. And so clearly, these high levels of clinical threshold for mood disorder are concerning. They map onto other research, although this is a small study sample, and so that needs to be accounted for. But thinking about this from a clinical perspective, those are very, very high rates. And these are also individuals, bear in mind, who are not receiving treatment. When we looked at suicide, 70% of the sample had expressed suicidal ideation in the past, and 45% had a past suicide attempt. After a while of things being rough, it will start to feel hopeless. It affects your mental health and how you view the world. My friend, his foster parents found out about his sexuality. They didn't take it well. He took a gunshot to his head. This happened like 3 years ago. We then looked at the relationship between a variety of sexual gender minority specific stressors, victimization, abuse, and rejection on suicidality outcomes. And this is what we found. So LGBTQ victimization increased individuals' suicidal planning. Similarly, gender identity victimization increased suicidal planning. Gender identity discrimination increased suicidal planning. Gender identity rejection increased suicidal planning. And sexual orientation rejection increased suicidal planning. Now, what I want to point out here that's very important is that all of these instances of violence, victimization, discrimination were associated with suicidal planning, not with ideation. There's other research happening right now looking at the crisis of suicidality among young Black folks and younger African American children. And in those research studies, there's the same phenomenon occurring where the associations are going to planning, in other words, sort of skipping over the ideation stage. And there's discussion among suicide researchers about how all of our suicide assessments focus on ideation first. But what if kids are not ideating? What if they are going directly to planning? And so that's something to highlight from what we saw here in our pilot study. Two other factors we looked at. One, everyday discrimination. So the sample that we're looking at, and LGBTQ youth in Cuyahoga County who are involved in systems are predominantly going to be African American, Black, mixed race. And so including everyday discrimination, was really important for this study. And when we look at that, we see that everyday discrimination is associated, again, with the whole range of behaviors: ideation, planning, attempt, as well as non-suicidal self-harm or self-injury. When we look deeper into this, you can say in the everyday discrimination, there's a variety of questions, like 12 questions, asking about experiences of everyday discrimination. And then there's a part that's open-ended, and it says, what do you attribute these discriminatory acts to? Now, in the original question, the original survey tool, it doesn't include sexual orientation or gender identity and expression. It has gender, but it doesn't talk about trans or gender diverse. So we adapted it to add those things. And when we look at those answers, people are checking multiple things. Folks are not attributing experiences of discrimination to a singular, quote, minority status, right? It is the experience of being an individual with multiple different types of identities that can be targeted at once. The other thing, we know that IPV is higher among sexual and gender minority youth and system-involved youth, so we also assessed for that, and that became another factor associated with ideation, planning, attempt, and non-suicidal self-harm. Okay. The next thing that we're very interested in, of course, is sources of support, supportive places and people. And when we look at this from a queer-centered perspective, we know that LGBTQ individuals have a long-standing history of finding supportive connections outside of intimate familial family because of stigma and rejection and all of those things. So we have some levels here that we looked at that came out of both the qualitative and the quantitative work: system-based types of supports, community-based, queer kinship networks, which are personal to the individual, and then their personal advocacy. At the systems level, an individual said, I used to have this caseworker. She was a white butch with a faux hawk and gauges in her ears and wore men's clothes, and she gave me men's clothes, and I even have the clothes here now. This was an individual interviewed in a residential treatment facility. Another individual said, because I spoke up for someone, and the supervisor at the group home, she gave me stigma. Because we had a transgender person there, and I'm listening to the staff talking about this young lady and calling her a he, and I'm like, well, that's not your place to do that. You're making them uncomfortable. And they lashed out at me about it. I don't remember the whole thing. And at the time for me, I was growing to understand who I was, because in my home, I grew up in a Christian home and scriptures was thrown at you. So we didn't talk about these things. You're going to hell if you're gay. At the time, I was outspoken, but I didn't speak up for myself. But I saw what people go through, and I was like, well, they're human just like you. This next quote is from an individual who said, I need someone that treats gender dysphoria. I cut myself because of the gender stuff. I had a very rough time in foster care. I've been suicidal. I wish my therapist could work on the gender dysphoria. So to hold that up against a quote from an individual that took place in a larger workforce training that I did with colleagues in DCFS, I was talking to an 18-year-old client, and because of the training, I knew the right questions to ask. I was the first person they'd ever told about being transgender and being forced to live as a female and all of the thoughts that cause depression. This kid has been in therapy for months and never even told the therapist. We were able to process how he felt he would never be a real man and never be accepted by real men and would disappoint his parents. The parents were amazing, and I knew they would accept anything, so he ended up telling them later, and it worked out beautifully. So there's a happy outcome. It was one of the best days of ever working there, all because I had the tools to use. This next set of quotes has to do with community, places, and people. I think every young person should be able to feel safe in the space that they're in. I think we talk about the skin that we're in, but the space is just as critical. If I don't have the space, I can't feel comfortable in my skin. And this individual was referring to the LGBT Center when we asked young people where they go for supports. This is one of the sites that was cited a few times by a few different individuals, both the place and also specific staff at that place. Someone else said, we need supports, yes, but not counseling, community supports. This is what I have now. I didn't have anything before. I didn't share deep about who I was before. And this is another individual who's talking about connecting with community spaces and people and those informal types of supports, not formal counseling. The next protective factor or resource that young folks described was their queer relationships. So these are chosen family and friends. I don't always want to talk about myself. I want to hear from other people, and that's how I grow. That's how we all flourish. I love Dominique as a chosen family member. I just don't want her to be so stuck in her past and what happened to her. It's a fear thing with her. She is trans, so I have to take that into consideration because trans women get it really bad, and you have to be really patient and mindful with that. So you know I love her. And this individual said, my queer friends are there when I need them. They're the ones who say it's okay to be LGBTQ. They're like my backbone. I need them in life. You never know what's going to happen in the future, you know? So from these experiences, working in this project for 4 years with DCFS and other community partners on that project, doing this smaller pilot study and also looking at literature, I worked with my team and we developed a paper. And these are 3 points that we know to be evidence-based intervention points to reduce suicidality among sexual and gender minority youth in child welfare system. So these are affirming policy and practice, chosen and constructed queer family, and family acceptance. A lot of different types of intervention research tends to focus on one point of intervention. But when we look at this as more of a systems dynamic, we can see that each of those separate intervention points is mutually reinforcing of other factors in this system. So intervention targets mutually and simultaneously impact outcomes. The team is now moving towards multi-level interventions based on this body of work and using, in part, system dynamics to conceptualize how the system is functioning and where we intervene, how those interventions will change the way the system functions and potentially and hopefully outcomes for young people. So there's 2 critical gaps that we've identified. 1, we lack system-level safe identification for sexual and gender minority youth at risk of suicide and coordinated referral to SGM affirming peer support during this period of acute suicide risk identification. Now, remember, when we're talking about system-involved youth, these systems are screening for suicide. It happens in DCFS, although we could talk a lot more about that. It'd be a separate conversation. It also happens in the juvenile court system. So these are places where young folks are being assessed, and if they are flagged as at risk of suicide, they are being directed through safety planning and connected to resources, sometimes inpatient, sometimes outpatient, sometimes community-based supports and services. The problem is that we don't have this. We lack sexual and gender minority affirming peer supports that's embedded inside the current crisis response system where our youth are over-identified and underserved. One, we're not asking the question. We might do a suicide assessment and not ask about gender identity or sexual orientation. So we're missing a whole piece of a story. Two, if that becomes apparent for some reason, maybe the youth discloses it themselves or an assumption is made because of how a youth looks, then there's not a great option in terms of referral. This is a problem that has come up over and over across the crisis continuum in Cuyahoga County. Hear about it everywhere. Hear about it from clinicians. Hear about it from folks doing homelessness outreach. Hear about it from folks at the LGBT Center who have young folks coming to their door needing a place to go and having to be turned away because of the hours. We hear it from the way that the hours of operation for places like Frontline don't always map on to when youth are in crisis and need to be assisted. So this is a broad systems problem. Over the past several years, I've been working with this constellation of individuals around intervention development. We have previous working relationships. You've heard about some of that today. And collectively, these are organizations and individuals, including individuals with lived experience as being SGM and in systems, have identified this as the research area need. We need peer support specialist services to engage and retain public system involved youth at risk of suicide in mental health treatment. Now, the use of peer support here is really important. The focus of the group, the focus of collaborators, and what young people themselves say is there's still a lot of work to be done in the area of clinicians, but the importance of using the peer support as a way to connect and build relationship and rapport to address evidence-based targeted risk and protected factors within that relationship and to help keep young people connected to care. One of the things that we did early in this team was looked at some juvenile court data. So as I mentioned before, juvenile court is doing suicide risk assessments. They also implemented screening of sexual and gender minorities about 4 years ago. They're working to build that up. What they hadn't looked at was the intersection, just a basic crosstabs on who says, yes, I'm a sexual gender minority, and who is also screening as at risk of suicide on our suicide assessment. So I'm sure the number is already leaping out to you. What you see there is this 41% compared to 16%, so almost twofold increase. So that's 41% of youth who say, yes, I'm a sexual gender minority, are also screening in juvenile court intake processing as at risk of suicide, either cautionary or imminent risk. That's compared to 16% of those also being screened for suicidality, but not saying, no, I'm heterosexual and cisgender. So looking at this data was really, really helpful for the system team people to have a point of reference and something to point to say, here is a real problem. We know it's here. We know this is an issue. We just haven't looked at the data. How can we start to leverage this? Okay, so the intervention concept, the next few slides I'm going to talk about are where the work currently is, and then we'll wrap it up and open up for questions. In terms of the intervention conceptual model for what we're developing now with juvenile court and frontline service and DCFS and the LGBT Center and A Place for Me and Thrive Recovery Services, a bunch of different players. If I forgot you, I'm sorry, you're important. All right. So the first thing we're going to talk about is the current system drivers, right? We have policies that are biased against SGM youth. Remember that even seemingly neutral policies can be biased. So when we're not asking the questions and we're not asking in a culturally affirmative and appropriate way, that is a system bias. Because of the system bias and not identifying, we have a system response that ignores the needs of these youth. and there's no SGM affirming connection to care. So our system targets then, the first layer of targeting, this is a multi-level intervention, is identification referral of sexual and gender minority at risk of suicide to an affirmative peer support worker who is embedded in the crisis continuum, working actually in frontline services. Doing this will target individual risk factors. We know that provider bias, there's a lot of mistrust of systems. That's a known risk factor for disengagement or lack of follow-up or connection to care, and also internalized queerphobia. And connection to a peer support specialist will build up these protective factors: community connection, more peer support, and self-affirming beliefs and hope. The interesting thing about this is that all of these factors, both the risk factors and the protective factors, those are risk and protective factors for two things: for behavioral health service engagement and for suicidality. That's not always the case. Sometimes you're targeting different kinds of factors for different types of outcomes, but when it comes to suicidality among sexual and gender minority individuals, youth, they're the same. So if we can build up these protective factors and reduce some of those other factors through the peer supportive relationship, that will, one, increase engagement with behavioral health care, and two, reduce suicidality. I'm going to leave you with a rather complicated picture of our intervention. But this is for the folks in the room that really want to see this kind of thing. So this is the, how do I explain this? Essentially, what we did we're in the phase of grant writing and resubmitting to various mechanisms for funding, right? So because I'm part of this already established learning community, Learning Collaborative, we held a series of group model sessions with key stakeholders across these systems to talk about the intervention and to talk about what it would look like in action. And using a system dynamic approach to that allows us to conceptualize the complexity of the system, how it's functioning, and to also identify in blue are the parts that we need to address, right? The different targets and their relationship to the different outcomes. So I know this is a sort of a crazy diagram to include in a talk, but it's kind of to spur any interest if there's folks in the room that want to connect later, talk about this. I'd be happy to do that. Okay. All right. That's it. Thank you.